Dr. Sahil Kumar Mandal, a very good, excellent oculoplastic surgeon. I have been seeing his work. He has received so many laurels for national and international. Thank you very much for joining us today. Next slide, please. So these are the rules and regulations. The time of presentation is very important. It is 4 minutes, discussion for 2 minutes, and the marks will be given on the basis of the content, the subject matter, the originality, the statistical analysis, and the likelihood of publication. So total 100 marks. And next slide, please. I think we'll be starting with the first presentation.
Good afternoon, everyone. I will be speaking on the topic of evaluation of the objective factors affecting the visual outcome of ONSF in patients with IH. It was a study in COVID era. IH is a clinical syndrome of unknown etiology in which intracranial pressure is raised in the absence of vascular space occupying lesion. It's a disease linked with obesity. Its importance lies in the fact that it can lead to irreversible vision loss. The mainstays of the treatment include weight loss and medical management, and those who are refractory to medical treatment, surgical intervention is required. Options include ONSF surgery or CSF diversion procedures. So why we did the study? Improvement of the stabilization in the visual outcome in the terms of both visual acuity and the visual field after ONSF for those who diagnosed with IH is documented by various studies. Few studies evaluated the demographic and patient subjective factors to predict the outcome after ONSF. The paucity of the literature still on this is objective factors like RNFL thickness, optic nerve sheath diameter to predict the outcome. So our primary objective was to evaluate the objective factors, both the functional and structural parameters affecting the visual outcome over the period of 3 months, if possible up to 6 months in patient diagnosed with the IH planning to undergo ONSF. It was an ambispective observational single center study. Sample size was 12 patients. Time period was 3 years. Place of study, Department of Ophthalmology, AIIMS, New Delhi. So after satisfying the modified Dandy criteria, the patients with the IH came to the neuro-ophthalmology department. Those who need the surgical management after meeting inclusion criteria were underwent a comprehensive history taking like associative factors of IH, age at onset of IH, time to ONSF, and general examination like BMI, weight, ophthalmic examination BCVA, anterior segment examination, clinical picture of the fundus to document the stage of papilledema, and other investigations, opening pressure of CSF, that already done in the Department of Neurology, OCT to evaluate RNFL and GCL IPL thickness, VER, USG for optic nerve sheath diameter. And after the comprehensive examination, patient posted for the surgery. All investigations were repeated on post-op day 1, 2, 6, 12, and 24 weeks if possible. So study recruited 12 eyes underwent ONSF surgery, and out of 12 eyes, 7 I evaluated the prospectively and remaining 5 is retrospectively onto COVID-19 pandemic. Mean age of the study group was 34.5, mean weight of the population was 66.5, mean BMI was 25.76, mean time to ONSF was 108 days. So coming to our major objective changes in the functional and structural parameters over the 6 months in either eyes. This is a best corrected visual acuity graph in which we can see there is an improvement in the either eyes in the post-op follow-up period, especially at 12 and 24 weeks in the operated eye and 24 weeks in the fellow eye with a statistical significant value. Coming to the amplitude of visually evoked response, there was an improvement in the either eyes with the p is equal to 0.04 that is statistically significant at 24 weeks in the operated eye. Now to this latency of p100, there was a significant reduction in the post-op follow-up period with p is equal to 0.02 and 0.046 at 6 and 12 weeks in the operated eye, and there was a significant changes in the 24 weeks in the fellow eye also. Now getting into this is OCT changes, RNFL thickness got decreased with a significant value of p is equal to 0.04 for both the operated eye at 6 and 12 weeks and at 24 weeks in the fellow eye. Coming to the GCL IPL thickness, it got stabilized over the post-op period even though no significant change was noticed. Now to this is optic nerve sheath diameter. On this is axial section, we can see that there is a significant decrease in the immediate post-operative period, especially in the operated eye with the p is equal to 0.02. We also done a correlation with this is pre-operative functional and structural parameters with the final visual acuity. There was a strong correlation found with the pre-operative visual acuity with the final visual acuity in either eye with this statistically significant value of p is equal to 0.04. There were also strong correlation found with the time of this is ONSF with the final visual acuity in both eye with R is equal to plus 0.83 in the operated eye and R is equal to plus 0.81 in the fellow eye. Pre-op ONST also showed strong correlation with the final visual acuity. So coming to the conclusion, ONSF surgery helps in either improvement of the stabilization of the visual acuity in either eyes, improvement in the objective parameters indisputably obvious the need of bilateral ONSF in all cases, improvement in the final BCVA primarily depends upon preoperative BCVA, time to ONSF and preoperative ONST on axial section. My limitation of the study was the sample size of the study was small, didn't represent the general population. This was an ambispecative study. Structural parameters couldn't able to assess in all patients. Thank you so much.
Any questions?
Hello. In which route we access the optic nerve?
Sorry, sir.
Which route you access the optic nerve?
Sir, we
Is it an endoscopic or open route?
No, sir, in the open route only, transconjunctival approach we have done.
You never tried, endoscopic route?
No, no.
So which part of the optic nerve is mostly you access?
On the medial aspect, sir.
Only medial aspect. But you go enter into the orbit through medial route?
Yes,
or the
sir.
lateral route?
No, sir, medial route. We have isolated the medial rectus muscle, and the part of this stump is actually we've kept it over there that after cutting the tendon, and we passed ethibond, 50 ethibond through that remaining stump, and then we retracted the globe and reached this retrobulbar space.
Yeah, what are the preoperative vision of this patient?
Sorry,
All
sir?
the patient preoperative vision.
Sorry?
Preoperative visual status. All the patient.
Most of the patients were PL positive, hand movement close to face, visual acuity, and we couldn't able to assess the visual field or color vision or contrast vision in our cases, sir.
Do you do VEP of that all the patients?
Yes.
Before surgery? And after surgery, what is the outcome?
The outcome after, especially after this is immediate post-operative period, what we found is actually optic nerve sheath diameter got decreased, but VR actually changes is coming nearly around 6 months only, sir. And
do you do any MRI in the brain to see the ventricle status?
sorry, sir. Sorry, sir.
MRI
brain.
of the brain
Yes, sir.
to see the ventricular status, the dilatation or anything else?
Yes, sir. We prior to the surgery, we see this is dilation of this. We should see this how much the nerve sheath is distended, and then only we will plan to operate the patient.
In the topic, why you added the word that this is study in COVID era? Is it making any difference?
No, sir, not because the sample size was too less, and none of the studies is not conducted recently so far, especially in this is ONSF. So just to highlight that only, not that much.
Any role of intraoperative and postoperative steroids you have not mentioned, or it is not a part of study?
No, sir. There is no role of this steroids.
Intraoperative.
No, sir. No role of the steroids in our center.
Ma'am almost does the same thing, like you need to compare your findings with the existing literature because that is part of your presentation.
Yes.
So I couldn't see the discussion part as such. You straight forward, like after results you went to the conclusion. So basically you have to do some comparison of what is the strength of your study or what is different from the existing literature should be highlighted.
Okay, sir. Objective factors evaluation we are doing the first time, and this is entire world. Maybe that might.
So we can go on to the next speaker. That's
Talking about my thesis, that is managing post-SFIL retinal detachment, functional and anatomical outcomes. I have done a thesis under the guidance of Dr. Pramod Bende sir, and my co-guide was Dr. Shobit. So recombinous retinal detachment is one of the most serious complications after IOL implantation surgery. Management of pseudophakic RRD differs from phakic RRD, as often there are chances of missing retinal breaks in the peripheral area due to the visualization difficulties. So my primary objective was to analyze the anatomical and functional outcomes of retinal detachment surgery post-SFIL implantation, and my secondary objective was to identify the intraoperative difficulties or modification needed during surgical procedure while managing these cases. It was a retrospective study done in the Medical Research Foundation, Shankar Nethralaya, Chennai from January 1999 to December 2021. The study population of patients visiting Shankar Nethralaya and fulfilling the inclusion criteria. Retrospective retrieval of data was done using the approval of IRB board at Shankar Nethralaya. The inclusion criteria were patients who develop retinal detachment following SFIL surgery during the surgery period and have a minimum follow-up of 2 months post-RD surgery. The exclusion criteria was all the patients who had other retinal disorders before developing RRD, which can affect the final outcome. Moving on to the result and discussion, it will be discussed under the following headings: preoperative evaluation, intraoperative findings, and postoperative findings. It was a retrospective study over a period of 22 years, having 4,529 eyes which underwent SFL implantation. 34 eyes of 32 patients developed post-SFL retinal detachment. So the incidence we found was 0.75%. This is a comparison data sheet with other studies of sample size of more than 100 eyes. The incidence was a little less in our study, probably because of the meticulous peripheral base shaving during the pars plana vitrectomy for SFL implantation and majority number of eyes. Moving on to the history, the main indication of SFL implantation in our study was congenital subluxation of lens. Usually eyes with congenital subluxation of lens are at higher risk of developing RRD, but the difference was not statistically significant in our study. Also, we found no co-association between the site of entry of needle and the location of breaks in our study, as was proposed by the study by Lee et al. In our study, only 20% of the eyes had PVR at presentation, which is less as compared to the literature. This can be because mainly of two reasons. First, the early presentation of the patient in our series. Second, majority of the breaks were atrophic in our cases compared to the horseshoe tear in other studies. Intraoperatively, all of our eyes underwent pars plana vitrectomy. 4 eyes needed additional scleral buckle to support the unrelieved traction. The silicone oil was used in 52% of the cases, while C3F8 was used in 47% of the cases for internal tamponade. This is a screenshot of all the eyes which underwent the procedure and how the whole procedure went through. The anatomical outcomes were the mean follow-up period was 56.7 months. The single surgery success rate was 85.2% and the final surgery rate was 91.1%, which was slightly higher than the known in the literature. The visual outcomes at the final follow-up had improved vision in 73.5% of the eyes. We also find a positive correlation between the visual outcomes post-retinal detachment surgery and the indication of SFL in our study. Visual outcomes were better in eyes where SFL implantation was done for surgical aphakia, p-value 0.027. Also, non-traumatic subluxated lens had a better visual outcome as compared to a traumatic lens subluxation for the indication of SFIOL. So, to conclude, though not very common, RRD is a very vision-threatening complication for post-SFIOL surgery. The incidence in our report was 0.75%. Thorough fundus evaluation and treatment of all peripheral lesions before SFIOL implantation surgery may reduce the incidence of post-SFIOL RRD. Location and breaks may not be necessarily correlated with the fixation sutures. Complete vitrectomy with peripheral base shaving should be done during SFIOL implantation. Pars plana approach is preferred in these cases, which helps to remove the performing good base shaving as well as removing the residual vitreous. There are some unique difficulties a surgeon face while operating these eyes, and like the condensation of the posterior surface of the eye during the fluid gas exchange and the air entry during the FGE. Surgical explantation almost never needed in these eyes. The etiology of SFL implantation was never may impact the final outcome, and these are my limitations, my references. Thank you.
Doing SFIL, what type of SFIL you are
In all of the 34 cases which we did, it was a sutured SFI, 4-point fixation.
Sutured with a Prolene suture, na?
Yes.
Yeah, double suture or single suture?
It was a Gore-Tex sutures which was used, and it was like 4-point fixation was done.
Okay. But you are not doing any tucking multi-disc lens?
We included only sutured SFIL in our case series.
Okay.
Because we were during the surgical one of our findings were we don't need to explant the SFIL because they are mostly stable. Out of the 34 eyes, only 2 eyes we had to explant the IOL, which were already subluxated at the time of presentation.
And only you are not mentioned the what types of RD? It is a fresh RD or old RD, or the subtotal RD or a total RD?
One of the chart I showed, we had presentation, 61% of the patients were having more than 3 quadrant involved at the time of presentation with us. So this was again one of the finding that post-vitrectomized eyes have an earlier presentation, which cause less chances of PVR changes, and then finally we will have a better functional outcomes.
After how many days that RDs happen after the SFI?
Usually in our series we found at a minimum of 15 days, earliest as 15 days, and as long as 5 years.
And what is your result after doing RD surgery? Doing external buckling or internal?
Yes,
external approach or internal approach?
No, it was always the internal approach. We always used pars plana vitrectomy because almost all eyes were partially vitrectomized or anterior vitrectomy was done while most important thing is while doing RD surgery in SFIL cases, there is a lot of visualization disturbances because of edge effect. So it's better, we might miss retinal breaks pre-operatively. So it is better to do it at internal approach so that we can see the breaks, which was seen in our study, like 29% of the breaks were not seen pre-operatively, but on table we could see it and we could laser it.
IOL is still in place?
Yes.
After doing it? It's
Yes.
okay?
Yes.
I just wanted to understand if this is your thesis, right?
Yes.
So how did you recruit the patients? Because were these the 34 patients that came during your 2 years? Or these were the 4,500 patients retrospectively? We usually in thesis, we give a, I mean, we don't like do a retrospective study where the student doesn't have to do anything.
So this
Like,
was a
that is a little.
this was a retrospective study. So it was 19 years in the past and 1 year, 2 years in the in forward, like from 2020 to 2021.
So the 4,500 was
Is
data
from 1999 because the sample size was too less. The incidence of the disease is like in the literature is also reported in 1 to 3%.
So during your 2 years, how many surgeries did you see? Is what the
Surgeries,
teachers are interested in, I think.
Okay, so the cases which were during my residency were 8, but out of that, the surgery I could see, because I was posted at a time, I could see only 3 of the surgeries being done.
So most of your thesis work was paperwork.
A lot of it was.
Is what we really have to think about when we give
But I
thesis.
think if you are looking at a topics where the incidence is very low, and your subject duration is only 3 years, so you have to do a lot of paperwork to get that data. Because in this study, we were able to also say that we should do a complete vitrectomy at the time of SFL implantation rather than just doing an anterior vitrectomy, because most of the results are much better after that.
So I don't refute the nature of the study, but my concern was the thesis part.
This is the suture arrival is most of the surgeons, they are doing a tucking with a multiple lines. That is much more stable. Suture will always have a vibration each movement of the eyeball. That may leads to a retinal detachment also. No?
What are the statistics used actually?
So multiple statistical methods were used. Like the most common was chi-square method was used, and there were 2 more statistical regression methods which were used to compare between the groups having anterior vitrectomy versus complete vitrectomy, between the comparison between the attached location of tears, what type of tears between the different studies. So multiple regression studies were also used.
What were your basic outcomes like? What are the outcome measures in your study like? What are you looking at basically?
So we are looking at a couple of things. Like first, 79% of the cases were seen within the first year of SFL implantation. So a regular follow-up within the first year is very important. First. Second.
No, what I'm asking is
No,
like
is
in
it-
your methodology, what are your outcome measures?
Primary and the secondary outcome.
Yeah.
What was your primary outcome and what are the
my secondary outcomes were we were
Primary?
discussing.
What is your primary? Yes.
Primary one was commenting about the anatomical and the functional outcomes of retinal detachment surgery post SFL implantation. The secondary one was looking
So
at.
functional outcome including visual acuity.
Yes.
Okay.
And my secondary was the difficulties which we faced during the surgery of managing RD when there is already an SFIL in place.
So will you use a chi-square test for a visual acuity analysis?
Chi-square, yes, we used for the visual acuity analysis also.
Okay,
It's
usually you can't because
percentage,
visual acuity is not a nominal data which can be
Yeah.
analyzed using chi-square
For
test.
percentage and all, we use chi-square, not for visual acuity.
To present to you my thesis, which brings 2 realms of medical field, which is psychiatry and ophthalmology together. Comparison of EDI-OCT features and anxiety scores in patients with central serous retinopathy versus controls. As we know, it is an idiopathic detachment of neurosensory retina because of pathophysiological changes at the Reich's complex. CSER is the archetype of pachychoroid spectrum, which was coined by Varro et al. In 2013. The major risk factors are stress and type A personality. Stress can be a cause as well as a consequence of sudden visual loss. And EDI-OCT enables us for a detailed evaluation of choroid and its vasculature. The primary aim was to compare the EDI-OCT features and anxiety scores between patients with CSER versus normal controls. The primary objectives were to compare the choroidal thickness and anxiety scores, and the secondary objectives were to study the other OCT features of CSER and to compare the demographics. It was an observational case control study. We recruited 100 unilateral cases of CSER coming to the retina services. 100 controls presenting to general OPD were recruited, which were age matched and gender matched. After consent, history, and slit lamp evaluation, a detailed EDI-OCT scan was taken of patients and controls, and anxiety scoring was done. The OCT parameters noted were choroidal thickness, subretinal fluid, pigment epithelial detachment, hyperreflective foci, and fibrin. We used the Hamilton Anxiety Rating Scale, which is a validated questionnaire consisting of 14 symptoms, and it is divided into 5 categories: not present, mild, moderate, severe, and very severe. As expected, 87% of the cases were males, and we took similar gender-matched controls. The average age in cases was around 39 years, and age-matched controls were taken. The choroidal thickness was, in cases, was around 448 microns, and in fellow eye also it was high, which is 398 microns. In controls, it was normal. Pachychoroid was present in 94% of the eyes with CSER and in 76% of the fellow eyes, thus reinstating the fact that it is a bilateral pathology. The other OCT features which were compared were, which were noted were subretinal fluid, PED, fibrin, and HRF were present in all the CSER eyes, while only 24% of the fellow eyes had a PED. Coming to the main part, which is the anxiety scoring, around 47% of the cases had moderate anxiety, 25% had mild anxiety, whereas only 7% had very severe anxiety. And in controls, 99% of the population didn't have any anxiety. Digging deeper, we tried to find out which symptom is most common. So we found out that anxious mood, tension, and insomnia were present in very severe category in around 40 to 50% of the population. Whereas other symptoms, somatic symptoms, respiratory symptoms, and cardiovascular symptoms were not present in most of the patient. CSER is because of the hyperpermeable nature of choroid, and it is also responsible for increased thickness in the fellow eyes. It is because of the corticotropin releasing hormone, which leads to stress. And in our study, we definitely we had a strong correlation between anxiety and CSER. To conclude, fellow eyes also have a thicker choroid, and thus the pathology is bilateral. Need for normative database is extremely important, which provides a platform for further research. And since it is a multifactorial disease, it requires a multidisciplinary approach and proper counseling. These are my references. Thank you.
Have you studied the recurrence of CSR in the patients having the high anxiety scores?
Sir, no, we took only treatment naive first-timers. I took only treatment naive first-timers in the study.
And the patients who are taking the anti-anxiety drugs, they are included, or?
No, sir. Just, no. Means only first-timers we recruited. No, ma'am, no.
How long the anxiety is responsible for your detachment? Is there any time period?
Time period means all these were...
In a day, that you are tension in some time, you are not in a same level anxiety, na? Anxiety fluctuating. So is there any level of fluctuation or increased anxiety level, decreased anxiety level that may responsible your detachment?
We have not...
No.
Any acute exacerbation, say something like a stress factor?
Randomized. Means the whoever all the CSR who were presenting first timers, we recruited those patients.
How you have calculated the sample size here? You have selected only 100 patients. Sample size.
Yes,
what method you have applied? And you have said that 99% of the control, 99% of the patients of the control are not having any anxiety symptoms. But the incidence of, how you have selected the controls? Incidence of anxiety is more than 1% in the general population.
one person had mild anxiety. All
From
these
where you have selected the controls?
the controls were presenting to the general OPD service.
Based on the scale.
Yes, ma'am. Yes, sir. Hmm. Yes, sir. No, no, we have done. Choroidal thickness was normal in controls, and sub SRF nothing was present. Few patients of the control group had PEDs.
Okay, so we can go on to the next. Good, good. Thesis. Next is Dr. Monica Singh. Is she there? No. Dr. Swasti Pandey? No. Dr. Nilima Matthew? Yeah.
Good afternoon. My thesis topic is functional vision assessment in children with global developmental delay coming to a tertiary care center. So vision loss early in life has profound functional and psychological implications. So vision impairment is known to occur in children with multiple disabilities. Hence, instead of doing only a conventional vision assessment in these children, we must also perform a functional vision assessment. So functional vision is defined as vision that can be used to perform a task or task which requires vision. That is how a person uses vision in his daily life. The information gathered from FEA is often quite different from what we see from CVA, and normal visual acuity doesn't necessarily imply a healthy visual system. So need for the study, goal of FEA is to determine what and how the child sees and what can be done to best facilitate learning through the visual sense. So identifying the range of visual limitations and strengths through FEA can help to plan early intervention programs and integrate with the multidisciplinary therapies. So just to see the difference between visual function and functional vision. So examples of typical visual functioning system includes visual acuity, field, contrast, color vision, etc. But in functional vision, we see the orientation and mobility, daily living skills, communication and sustained near activities. So in typical CVA, it will be each eye separately, but in FEA, the fourth will be measuring for the person as a whole. And method will be variable stimulus with a fixed threshold performance in the conventional assessment. And in FEA, it is a standardized task, variable performance or with difficulty. So test will be single variable under control conditions, and the other will be multiple variables. Coming to aim, primary aim is to assess functional vision in children with global developmental delay, and secondary aim was to correlate functional vision with the severity of disability and also with the conventional visual acuity. Inclusion criteria, GDD, children from 6 months to 5 years were included. Exclusion, any primary ocular disorders like cataract, congenital cataract, glaucoma, vision-threatening ROP, retinal conditions all were excluded. Study design, cross-sectional observational study. Methodology, children in the age group of 6 months to 5 years. Diagnosed with GDD, we refer to ophthalmic evaluation, detailed birth and perinatal history noted, and ophthalmic evaluation done in 2 stages, that is conventional and functional. During our first visit, visual acuity was assessed using both qualitative and quantitative tests. And children were then called for us. Also, we did the contrast sensitivity, ocular motility and nystagmus, anterior segment examination, refraction and fundoscopy, and glass prescription was given based on AAO guideline. Second time, the children were called for the functional vision assessment. So the following components were noted: visual attention, vision for orientation and mobility, vision for communication, cognitive vision. Our scoring was based on the visual function classification system, which had 5 scales. So GDD, children were categorized based on the development quotient. So statistical analysis was done using chi-square and man-Whitney test, and a p-value of less than 0.05 was considered as significant. So results include we had our age range was 2, interquartile range with 1 to 4 years, 66.7% were males, and we found different associations of the global development delay, and etiology birth asphyxia is the most common cause in our study, And MRI findings, hypoxic ischemic encephalopathy or PVL findings were more common with the severity of GDD. Ocular diagnoses were categorized, and mean visual acuity and other typical vision function was noted. Also, functional vision variables were noted. So, functional vision showed significant correlation with the conventional vision. Severity of GDD was correlating with the vision impairment, and there was also significant association between presence of microcephaly and seizures with the vision impairment. These are the limitations of my study, and conclusion, FVA is a valuable tool which can help us to understand how the child uses vision in various day-to-day tasks. Thank you.
For your visual field, when the child is suboptimally cannot understand, how do you prevent him from looking towards the, I mean, it's very difficult to manage a visual field in such children because you have to keep looking straight and there is hardly any, I mean, I don't know how you did it. So how did you do it? I have a special child, I want to know. So I have never been able to do it for my child.
Ma'am, illuminated toys, something like that.
No, but the child will look towards that, right?
No, ma'am, we centered this, maintained the fixation with the illuminated toys. So the child will be looking at that direction, ma'am.
But non-verbal children you cannot?
Even non-verbal children, ma'am. When we showed the illuminated toys, the child tend to look into that direction and fixate in the direction.
You reduce the size and the intensity?
No, ma'am, like a standard size was noted. But some children responded to...
Retina will have more vision than the central. So you cannot use the same size objects for the central and the peripheral.
No, ma'am. Periphery we used a little bit smaller ones compared to the...
You should document what you actually did rather than theoretical for us to hear it.
Video would have helped, yeah, probably. But I think 4 minutes, that makes it less. Yeah.
This must be your thesis topic, no? So you are actively participating in this. So have you mentioned the causes of GDD in your list?
Yes, sir. We had classified the causes. So birth asphyxia came to
Use the mic. Yeah.
Birth asphyxia came to be the most common cause. So MRI features also showed the same. Hypoxic ischemic encephalopathy, periventricular leukomalacia was common cause for the GDD.
Did you apply any retinoscopy in any patients, your patient?
Yes, sure, sir. We did a dynamic where possible and also after dilated retinoscopy also.
Also, okay. So how many patients having a visual problem in your study?
Sir, refractive errors, sir?
Yeah. Which type of refractive error and how will you improve the refractive errors in your study?
We studied about the refractive error, like it was not classified. We didn't correlate the type of refractive error as such. And
is there any squint of any patients you study?
Yes, sir. Strabismus was also noted.
Then you have to do full correction of the retinoscopy, you know.
Should we go to the next?
Thank you.
Dr. Harsha, are you here? And after Dr. Harsha is Dr. Pragati. Dr. Pragati, you are there? Yeah. I mean, this participants, you don't go, you need to collect your certificates.
Good afternoon, everyone. I'll be talking on the evaluation of diagnostic utility of serum ACE, MAN2 and lymphocyte in ocular sarcoidosis and tuberculosis. Ocular TB and sarcoidosis are two diseases with overlapping clinical features, and differentiating one from the other is a challenging task. They are even postulated as opposing presentation of the same disease spectrum. Sensitivity and specificity of ACE, MAN2 and lymphocyte vary in different study populations. Studies depicting their utility in combination are scarce and are quite relevant in TB endemic countries like India. The purpose of the study was to evaluate diagnostic utility of ACE, MAN2 and lymphocyte both in isolation as well as combined in the diagnosis of ocular TB and sarcoidosis. The outcomes were sensitivity, specificity, positive and negative predictive values. This was a prospective observational study done for 2 years in Aravind Hospital, Pondicherry in 95 patients with uveitis of age more than 18 years. We excluded patients with history of trauma, immunosuppression, ACE inhibitor use, and steroid use. The diagnostic criteria used were the revised AIOS criteria for sarcoidosis and Gupta et al. Criteria for TB. Serum ACE was estimated using a substrate FAPPG. We analyzed 118 eyes of 95 patients. Ocular TB was seen in 12% of the study population and sarcoidosis was seen in 20% of the study population. ACE was elevated in 89% of sarcoidosis and only in 33% of ocular TB. The mean value was 76.2, which was statistically significant compared to TB. MANTU was positive in 58% of TB patients and only in 15% of sarcoid patients. The mean value was 12.67, which was also statistically significant. Lymphopenia was seen only in the sarcoid group in 10% and it was not seen in the other groups. The elevated ACE had a very good sensitivity and negative predictive value in detecting ocular sarcoidosis. Negative MANTU also had a very good sensitivity and negative predictive value. Since lymphopenia was seen only in the sarcoid group, the specificity and positive predictive value was as high as 100%. Also, when the three parameters were combined, the specificity and PPV became 100. In ocular TB, both elevated and non-elevated ACE had a good negative predictive value. Also, the positive MANTU had a very good negative predictive value of 93.4. The area under ROC curve in sarcoidosis was maximum for elevated ACE. When compared to lymphopenia and negative MANTU, this was statistically significant. In ocular TB, the AUROC for positive MANTU was 0.83. This was also significant. To the best of our knowledge, no study conducted so far has tested the combined utility of elevated ACE, negative MANTU, and lymphopenia in ocular sarcoidosis diagnosis. Also, we analyzed the utility of serum ACE in ocular TB. This was an observational study where randomization was not done. Also, the study happened during peak phases of COVID, so viremia could have affected the lymphocyte value. We didn't have any biopsy-proven cases. Subjects were either presumed or probable sarcoidosis or probable and possible TB. Elenga et al. Study from South India says ACE was an independent risk factor rather than ACE and lymphopenia in combination, whereas Scott et al. Says the combination improved the diagnostic performance. According to our study, when combination of elevated ACE, negative MANTU, and lymphopenia used, there was a better ability to diagnose sarcoid rather than this test in isolation. As NPV is very high, in subjects with normal ACE, further screening test for sarcoid is needed only in case of strong clinical suspicion. Even though ACE was elevated in some patients with TB, it may not serve as a diagnostic tool in detection of TB. As NPV is very high, in case of negative MANTU, further screening test for TB may be necessary only if there is a strong clinical suspicion. Since serum ACE level is also a better test compared to negative MANTU and lymphopenia in discriminating ocular sarcoidosis from other diagnoses. Also, MANTU is a better test for discriminating TB from other diagnoses. These are my references. Thank you.
Lots of sophisticated taste in TB. Why you are using MANTU?
Sorry, sir.
Lots of sophisticated taste to diagnose TB and sarcoidosis. Why you are in choosing MANTU taste?
Sir, I didn't get it.
Better test for diagnosis of tuberculosis. You're using MONTU, but there are other tests also, more sophisticated.
Yes, sir. The gold standard test is basically biopsy or demonstrating the mycobacterium tubercle in fluid, but it's a very invasive test. And so also ocular TB when compared to extrapulmonary TB is paucibacillary. So even if we take so much effort and do an invasive technique and demonstrate and try to demonstrate, because of its paucibacillary nature, the test may be negative. So this is very easily viable, and in a country like India, this is more economically also viable for the patient. So when there were similar published literature when they combined different parameters. Yes. These parameters were chosen based on the diagnostic criteria, sir. Madam, basically ocular TB and sarcoidosis are two mimicker. No, but there was no published literature saying the specificity is quite good and positive predictive value.
Okay. Thank you. Next, I call upon Dr. Pragati Tiwari.
Good afternoon all. The topic of my thesis is estimation of the anterior chamber angle parameters using AIOS-ARC, anterior segment optical coherence tomography, and biometric parameters parameters using optical biometry in eyes with suspected occludable angles and open angles. There are no financial disclosures or conflicts of interest. So as we all know, primary angle closure disease is a progressive disease that gradually leads to glaucomatous optic atrophy, which is an irreversible form of blindness. In fact, in the Indian subcontinent, patients presenting with acute angle closure progress to have a chronically raised IOP in 71% cases, glaucomatous optic neuropathy in 39% cases, and blindness in 15.3% cases. The dimensions of the anterior segment structures determine the likelihood of development of angle closure, and using non-invasive imaging modalities, we can assess those parameters. Early diagnosis and intervention can not only slow down the progress, but also prevent permanent optic nerve damage. So the rationale behind the study was as follows. Many cases are undetected. Gonioscopy, although is the gold standard, but has an inherent subjectivity to it, is a time-consuming and often avoided procedure. So this calls for a need for non-contact procedures like anterior segment OCT and optical biometry, which can objectively evaluate the angle parameters, make us understand those parameters, and can be compared. And the lacuna in this topic is that there is paucity of data comparing the angle parameters and biometric parameters between the two groups that we mentioned. So the primary objectives was to compare the anterior chamber angle parameters that were measured by AIOS-ARC in suspected occludable angles and open angles, and the second one was to compare the biometric parameters using optical biometry between the two groups. The secondary objective was to find the level of agreement in the calculation of eye to white and CCT by AIOS-ARC and optical biometry. So the study participants were basically patients aged from 20 to 60 years with Van Herrick grades of 0, 1, and 2, without any ocular pathology, cataractus changes, or anything that could affect the angle parameters. So these were the suspected occludable angles, the group 1, and group 2 were open angles with Van Herrick grade 3 and 4. This is how we calculated the sample size, and the minimum sample size in each group was supposed to be 30 eyes. So the design was an analytical cross-sectional study performed at a department, and the study recruitment was for 1 year. 128 eyes of 64 patients were recruited, and group 1 had 68 eyes and group 2 were open eyes. All the patients who were presenting to the OPD underwent a Van Herrick examination and were grouped, and they underwent AIOS-ARC and optical biometry, and the outcome variables were established. So Van Herrick grading, as we all know, this is how it was performed. So this is the AIOS-ARC measuring the CCT and the angle parameters using the tools. We had used a Heidelberg Spectralis machine with the ASM module, and all of the locating the scleral spur was the most important, which was done, and all the parameters that are listed here were calculated for both nasal and temporal. And lens vault and white to white was also calculated. Similarly, IOL master was performed following this, and these are the list of the 5 parameters that we assessed and documented and compared. So these are the outcome variables that we got, 6 parameters on AIOS-ARC and these many on IOL master. Means were computed and compared, and the results, age and gender, I won't go into. Most of the data that we got was normally distributed, and following this testing, we established that all the parameters that we measured were significantly different between both the groups for both AIOS-ARC, and the biometric data was also significantly different. I'll skip these 2 slides. So our results, there were smaller parameters in suspected occludable angles with a higher lens vault, and optical parameters were smaller in the suspected occludable with a higher lens thickness. Previous literature has not compared these 2 groups, and the Spectralis machine AIOS-ARC device has only been used thrice in 3 studies according to the literature that we had searched. Limitations includes that the sample size was smaller, the limited duration for recruitment, and this was not a prospective study but a cross-sectional study. So we further recommend for prospective and multicentric studies, which can be performed to assess the ability of AIOS-ARC and optical biometer to detect progression of the angle closure and validate these findings. So to conclude, AIOS-ARC can be used for assessment of the angle parameters, and we can further understand and make kind of a cutoff value that can further establish us whether we can, how to further proceed. Sorry, I crossed my timing.
Did you do a gonio in all these patients?
Yes, sir. Yes, sir.
All of them?
All of them, sir. And that standard management was performed. If it was occludable, then we went ahead with LPI, with laser peripheral iridotomy. measurements were done before we performed the gonioscopy.
And in your study, you do all the cases gonioscopy?
Yes, sir. We did for this. So the standard of management is for shallow AC was that. So we did perform. And even for open angles, since it was
No,
a...
you means the occludable angle, lah?
Yes, sir.
Occludable angle is best seen by gonioscopy or your ASOCT?
So both were done. Initially, we performed the AIOS-ARC parameters because it's a contact procedure. Gonioscopy is a contact procedure. So we did not want anything that could compromise those micromillimeter, those values. So that was done first, and then we...
Even if you do compress the cornea, sometimes the angle become open.
Yes, yes, doctor.
That is the advantage for the gonioscopy. The glaucoma specialist must be known the gonioscopy, otherwise
I
difficult.
used a Sussman 4-mirror gonioscopy for all the patients.
No, I have a clarification. Like you have classified the groups based on Van Herrick's grading.
Yes, sir.
So how can you actually say that group 1 is occludable only based on Van Herrick's grading?
I agree with that, sir, but this...
Because Van Herrick's 2 can be an open angle on gonioscopy. So without doing a gonioscopy, you cannot actually say like these parameters are good based on a Van Herrick's classification, because Van Herrick's is not a gold standard to diagnose an occludable
Yes,
angle.
sir. So there was a similar study that I had quoted here. They had actually
They assessed all three.
compared... Yes, sir, all
They
three.
included
Yes, sir.
gonioscopy also.
So the idea behind this was, there is a study that has quoted that the gonioscopy is very less performed. They have actually compared the percent. So my idea was that clinically it's much easier to do a Van Herrick grading that is very commonly performed. So what if we can just look at that, see which are the suspected, do that grading, and just send them off for an AIOS-OCT. That is, although
still it
I'm
will-
not denying the
No, but
importance
still it
of
will come under
gonioscopy here.
suspect only. No, you cannot actually
Yes.
diagnose it as occludable.
Further, we can, so that was the idea. If there is no study actually has compared these, based upon these Van Herrick findings, two groups have not been compared. So I wanted to find that out. If there is difference, significant difference, statistically significant difference between these two values, which was there.
Or else you could have done one thing. You have done gonio in all these cases after ASOCT. You should have put that and compared. At least those results should have been provided, like whether those ASOCT parameters are matching with the gonioscopy
Could have
findings.
included, yes, sir. Yes, I agree with that, sir.
Okay, with this, we have come to the end of this session. I request all the judges and chairmen to kindly receive the certificates. So first, Dr. Vinod Ratra. Anyone to take a photograph? Pragya? Yeah. So, privilege. Now Vinod will give it to me. Dr. Pooja Bang, please.
You can go there.
Yes.
Come there.
Yeah, he's
Photos will come better.